Hello, everyone, and welcome back to the show. We're doing a highly requested episode today. I've done so many episodes on like iron and ferritin over the years of this show basically being up and running, but I haven't really done an episode to dedicate towards like all of it together. So I'm gonna attempt to do that today, just so it's kind of all in one place for you so we can talk about things like iron, ferritin, labs, root causes, and my recommendations on like how to fix this. Um, so let's jump right in. In terms of iron and ferritin, just kind of talking about these like whatever, in case you don't actually know what I'm talking about, because I talk about them every day, but it's definitely not common knowledge. Although I feel like awareness is improving within the running space. But iron is definitely like a micronutrient, a mineral that can be an issue in athletes, especially runners tend to be more at risk for low iron status, we'll call it. There are several labs that we can draw to help us understand what your iron status is. And we'll go over those today too. But that's kind of what I mean when I'm talking about iron or ferritin, or even just like using them interchangeably, although they are technically slightly different things. Ferritin is like a storage form of iron, and it's a very important lab to understand your iron status. But iron is a mineral that essentially we need to get through food. It is involved in red blood cell health, in energy levels in the body, and a lot of other things. And symptoms that maybe your iron status is not optimized or not within good standing. It's kind of the same symptoms whether you have a really low iron status or a really high iron status and you're overloaded, which is why it's super important to get like actual testing done to understand where you lie, because we would obviously treat these things very differently. And if you are iron overloaded, further testing may be needed to rule out things like hematochromatosis, which is a genetic condition. But I digress. So the symptoms are things like just general weakness, fatigue, feeling short of breath. And this often goes into dizziness, especially when you stand up, poor performance, or feeling like you just have heavy legs or have lost that pep in your step as an athlete. Those are super common things that I hear in practice. Pale skin, brittle hair, and nails, or even hair loss are very common symptoms as well. Headaches, feeling cold all the time, especially in the extremities, and sometimes more menstrual cycle symptoms like more clotting, more cramping, more symptomatic periods are also really common to see with iron issues, essentially. So that's just to name a few symptoms. What I've learned from working with hundreds of people is that a lot of people, especially women, are really good at just kind of living with these symptoms. And they don't sometimes always notice that there's anything wrong until we get some testing done. We do some interventions to improve their values, and they're like, I did not know how tired I was until I was no longer tired. So just because you don't maybe recognize these symptoms that you have as like severe doesn't necessarily mean there isn't a problem, especially if you do feel like there's just kind of been like a slow trajectory downward in how you feel generally over time. Sometimes it's really hard for people to like pinpoint certain symptoms. And there's other symptoms too that I hear that aren't as common, but are like just quirky individual symptoms, things like lung cramps, feeling like you can't take a deep breath, gasping, those types of things. So, just to go over iron intake needs for the general population, there's not necessarily reference ranges that are different for athletes for iron, like daily recommended intakes, but there are reference ranges recommended for athletes for like lab values. So, we'll go over those too. So, for females between the ages of 19 and 50, we want to see about 18 milligrams of iron per day. It's the same for men within the same age range. For over 50, we have it drop down to 8 milligrams. For pregnancy, we see 27 milligrams of iron needed per day. For lactation, without a period, So breastfeeding, but you don't have your period back yet, between 9 and 10 milligrams per day. Likely more, though, if you are breastfeeding with a period, which is possible. Um, Ask me how I know. But so these are kind of just like the recommended intakes. Now, we know from research that more than 50% of female athletes are iron deficient. That's a lot. That's over half. We also know that at least half of all female athletes are underfueling. And these two things, you bet your bottom dollar, are absolutely related. And we'll talk about why over the course of this episode. So we know that they're either not getting this much iron through their diet every day because they're just not getting enough through the food sources that they're choosing. And I do tend to see a lot of like fear around eating things like red meat or seafood. I don't know if it's because like we were really hammered with like this is bad for cholesterol over time when that's not really true. Or it's just unhealthy, quote unquote, or not clean, also untrue. But I do see that sometimes you can be at a higher risk if you are a plant-based athlete because the iron sources we get through plant-based food, which are non-heme rich sources, are absorbed at a much lower rate than iron that comes from animal-based foods, like red meat and that type of thing, oysters, seafood. But the iron that comes from the heme-rich sources and animal products also is not absorbed at a very high rate. So iron in general is kind of hard for the body to absorb, but it is an essential mineral. Plant-based sources may include pumpkin seeds, beans, lentils, legumes, nuts and seeds. Dark leafy greens have a little bit as well. Dark chocolate, dried cherries, dried apricots have some iron in them, and various whole grains as well, tofu, soy products. But again, they're just a little bit less bioavailable. So where does iron loss come from? So we know that people, who are runners are often deficient, but where does like normal iron loss come from? And then we can talk about some abnormal iron loss as well. So iron loss can come from, of course, menstruation, which is why female athletes tend to be a little bit at higher risk of iron deficiency, just because they do have to deal with monthly cycles, or monthly bleed, even if it's coming from, like a hormonal birth control pill. And it's estimated that we can lose 1 to 6 milligrams of iron per cycle, which of course is within normal limits. Some people might lose more if they have heavier cycles. And that's pretty significant. What I tell people to get their iron labs tested, I'm often saying, like, if you are a menstruating athlete, if you can try to get it tested like around the same point in your cycle, just so we're comparing apples to apples each time, that can be helpful because there can be a discrepancy in your labs before you start your period versus after you just finish it. And I think understanding your menstrual health is helpful so that we can understand, like, is this, more significant than it should be? And do we need to do some digging on the root cause of that so we can fix that to essentially literally stop the bleeding and improve your ferritin status from a root cause approach, without just slapping a Band-Aid iron supplement on it? Or is this a normal healthy cycle? We're going to have some discrepancy in our labs, and that's fine, but that's a legit loss every month. We do lose a little bit in normal digestion as well. We also lose some in GI malabsorption and digestive issues that are not normal, like low stomach acid, various infections, IBD, small intestinal bacterial overgrowth. There's a lot of reasons we can be losing blood internally. That is, of course, something we want to do some digging on as well. Ulcers, polyps, those types of things, other forms of internal bleeding outside of the GI tract. So that's definitely something that we want to risk assess for when we're trying to figure out why the heck this keeps happening. We lose iron in sweat. It's estimated about 0.3 milligrams per liter of sweat. What's common for a lot of runners, like kind of average sweat losses, is we'll lose about a liter per 1 to 2 hours of exercise, like continuous exercise. If you're a heavier sweater, obviously you'll lose a little more. If you're not a heavy sweater, you'll lose less. So again, if we've got an athlete who's exercising 1 to 2 hours per day, on average, who's a moderate to heavy sweater, like this becomes significant over the course of a week, especially in peak training. We also have iron loss from foot strike hemolysis, particularly in runners. High impact sports like running tend to be more at risk for this, where basically the impact of our foot hitting the ground hemolyzes or breaks apart red blood cells. And that just means we have to create more red blood cells more frequently than the average person, which requires more iron, because we need iron to make and oxygenate our blood. So that can be, a component of this as well, where runners may be more at risk for this than cyclists. Donating blood. This obviously is going to make you lose blood and be a significant loss of iron. This actually was happening so often in some of my like one-off client consults that I would have, that I started asking this point blank on my intake form, like, do you donate blood? Yes or no? If so, how often? When was the last time? It's my personal opinion that a lot of female athletes probably shouldn't be donating blood. I appreciate everyone who does donate blood, because, we know that we definitely need that as a society. And it's a great resource for people who need, blood transfusions. But let's leave it to maybe the people who don't have iron deficiency, because a lot of the times what happens is your hemoglobin might be checked before you donate blood. And if it's normal or above 12.5, you're allowed to donate blood. Now, we can be iron deficient with a normal hemoglobin. That's super common. So people often will go in iron deficient, but they don't know it because they haven't had the right labs checked. American Red Cross says 12.5, you're good to go. They take a bunch of blood from you. Now we're really in a hole, and it can take a while for that to replenish, especially if you're not doing like extra things to try and help that along and continuing to train at a high level. If you've been told by, a blood donation site, your hemoglobin's too low, like we're not going to let you donate, then you're probably past iron deficiency and we're into anemia territory. And that's just a more advanced stage of this that needs to be addressed and understood. We could also have iron loss from trauma. So if you have had like acute trauma, car accident, surgery, pregnancy, and birth, are all considered, traumatic, surgical medical events too. Those are all examples of other ways that we could lose like more iron. So lots of different places that this can come from. If you know that your ferritin is low, or you discover that, I'm going to talk about some of the most common reasons as well. So stay tuned for that. But first, let's talk about how to check on your iron status. So there's several labs that we should be doing to have a good understanding of what your iron status is. And what I don't recommend is going and getting these labs I'm about to say by yourself and then just doing nothing with them, or not sharing them with a provider who is competent in athlete lab values and sports nutrition. A lot of primary care providers are amazing. They are experts in so many things: athletic sports nutrition and athletic needs, and low energy availability and relative energy deficiency and sports syndrome, which are really common causes of this. Eating disorders even are not always things that they specialize in unless they have sought this out themselves. This would be really good information to share with a sports medicine physician, or with a sports dietitian. And not even, again, like a regular dietitian, not a bad resource, but probably doesn't know some of the ins and outs of these different lab values and reference ranges. When I was just a regular dietitian, when I was first practicing, I did not know this stuff until I sought out the continuing education on athletic and sports specific things. So you really want to be sharing this with the right individual so that you get the right type of interventions, and you don't just get told, take an iron supplement, good luck, because that's not the only intervention that most people need in order to get this to improve. So the following labs that we want to check are ferritin, serum iron, complete blood count, total iron binding capacity, iron saturation percentage, are the ones that I like to check as like a baseline. If I know the person really well and I've done further assessment on them, sometimes I also recommend other things. But it's really important to note that if you're asking about labs with a provider, Ferritin and serum iron are different labs. I can't tell you, I don't know why, but I can't tell you how many times someone has said, I will go get these labs. I asked for ferritin specifically, and then their provider ordered serum iron and a complete blood count. This is great, but it's not helpful. The gold standard for diagnosing iron deficiency, especially in athletes, is having that ferritin value on board. We want the other labs on board as well, just in case there's anything wonky to help us put into context what's going on. Your serum iron is going to change basically day to day, depending on what you've just eaten. If you just took an iron supplement, if you just went for a run, if you just had your period, if you just ate iron-rich foods, it's gonna go up and down kind of more acutely, depending on what your situation is. Your ferritin is the gold standard for measuring iron deficiency because it's the storage kind of protein that dictates iron status. And it's going to be the thing that tends to take a hit first when we're at the beginning stages of this. So we want it to be at least 40 ng per ml for females, especially athletic females, and 50 ng per ml for male athletes or athletic males. And obviously, this is a lot higher than your typical reference range, which can start between 10 and 15 ng per ml, depending on the lab. So you might have a ferritin of 20, 30, 19, and be told, you're fine, don't know why you're tired or feeling all these symptoms. But if you told that to me, I would say, oh, of course, this is why you're having some of these symptoms. And this is something that needs to be addressed. So again, some doctors will say, oh, you're at the lower end of normal. Let's do something about that, which is handy. And a lot won't, in my experience, working with, again, hundreds of people on this every single day over the years. So stage 1, iron deficiency, which is a proposed standard essentially for athletes, is if your ferritin is below 35 ng per ml and your hemoglobin, your serum iron, and your total saturation percentage are essentially normal. So if those are normal, but your ferritin's below 35, this is iron deficiency, or I've also heard it called iron insufficiency. This is super common. I see this really, really often, really often in practice. And this is why if you were to just test hemoglobin, iron, and total saturation percentage, and they were normal, you might get missed. You might get lost in the sauce here because we didn't test ferritin. And if your ferritin comes back at 29, oh, now we know this is an iron insufficiency issue, even though these other labs were normal. Stage 2, iron deficiency without anemia. This is if your ferritin is below 20 ng per ml. Your hemoglobin and iron are probably normal, and your total saturation percentage is under 16. Okay, so this is the criteria for that. Also see this all the time. So kind of, again, same thing, why it's important to check all of these labs. Stage 3 is iron deficiency with anemia. So this is if your ferritin is below 12, if your hemoglobin is below 11.5, and if your total saturation is below 16%. So this is usually what general practitioners in conventional medicine who may or may not have like a sports nutrition background, this is usually what they're testing for, what they're looking for. And if you don't fall in this category, you're probably not going to get any type of like intervention or advice on how to fix your symptoms and fix your status. If you are in this category, you're probably going to be recommended to go on an iron supplement that may or may not be a prescription. You may be recommended to get iron infusions or even blood transfusions if your red blood cells are also low, and you're struggling in that regard, which again are not bad interventions. But if we're not assessing, hey, why was this like in a hole? Why was this so low? We are missing the plot here because it's probably just going to happen again as soon as you stop getting the infusions or as soon as you stop taking the supplement. Or maybe you get the infusions and feel like crap. Or maybe you start taking the supplements, but it's not helping. Again, that's where the deeper digging really needs to happen. And that's where people usually end up, quote unquote, in my office because they're like, I'm taking this supplement and it's not working. or I'm taking this supplement and I feel awful, or I have all these GI issues because of the supplement. So it's making it hard to even take. Or I don't want to eat red meat and I'm a vegetarian, but that's like the only advice I've been offered. It's just not that helpful. And it's a very reactive way to look at this issue rather than being more proactive root cause approach, which is where I tend to fall somewhere in the middle. So if you're like, okay, I got these labs done, I know that my iron status is low, stage 1, stage 2, or stage 3, you know, what do I do here? Or like, what do I do if, yeah, I tried the supplements and it's just not really going up? I also think it's important to understand, again, why it's important to do labs with a competent provider, because we need to be rechecking these labs. Like, we should never just be giving you infusions or putting you on an iron supplement and like not rechecking labs. We need to recheck labs usually within like 1 to 6 months, depending on the case. Because we don't want you to end up iron overloaded, which is also a significant issue. And I see so many people do like an inside tracker test or go get labs done or just look at their labs, and maybe their PCP was like, you're fine, but they know because they follow me that they're not fine. And they're like, I'm just going to go take a random iron supplement and hope for the best. This is not a good strategy, okay? Again, because you're putting a Band-Aid on the problem. Why was it low in the first place? And also, you could be overloading yourself on iron if you're not rechecking your labs properly within 1 to 6 months, or repetitively within that time frame. Because we want to understand, one, is that intervention working? 2, is it too much? I often see people reach for things that are trendy because they heard like a professional athlete or a dietitian talk about it, like Hemoplex, which I pretty much never recommend, by the way. Super high dose of iron, and they just don't check their labs again. This is a problem. This is not going to get you where you want to go. So hear me out. So if this is the case and you're like, my ferritin's still low, what do I do? It's possible that we miss some key factors. So iron losses from the body, I know we talked about all the different ways we can lose iron, on average is about 1 to 2 milligrams per day, probably a little bit more with athletes. And again, if we're supposed to be taking in like 18 milligrams of iron for a lot of people, the rest is recycled. Like, what we're taking in is often recycled in a process that I'll talk about a little bit on here. It's hard to talk about it without visuals, but this is something that, again, a lot of the time, sometimes the iron intake isn't even the problem. Like, you're meeting your iron needs, but it's not getting into storage form. It's getting stuck in the tissues. It's getting stuck in the bloodstream. There's a transport or absorption or recycling mechanics like issue. And that's actually what we need to address. We need other micronutrients like copper, vitamin A, and magnesium to transport iron from the tissues to the blood into ferritin for storage. We don't want to necessarily just supplement these things either, because guess what? Minerals, they're all synergistic. If you take too much zinc, if you take too much calcium, if you take too much copper, your iron's going to be off. If you take too much iron, guess what? All those other all those other minerals are also likely going to be off. And the symphony is sounding not so good because it's not in synchronization. Okay. So other key things that we could be missing. And like here, if I lost you, come back to me now. Okay. Are you back? The biggest key issue that I see in athletes time and time again is that they are not eating enough and their carbohydrate intake is too low. And you may be thinking, what the heck does that have to do with iron? Iron isn't even really found in carbohydrates. If your carbohydrate intake is too low, you are going to be in a state of low energy availability, even if you are technically meeting your calorie needs because you're getting enough protein and fat. Okay, let me say that again. Low carb, usually for a lot of athletes, equals low energy availability like state in the body. If you're also not getting enough of the other macronutrients, protein and fat, chronically over time, if this has been happening for like over 1 to 3 months, that's considered chronic. You probably have relative energy deficiency in sport syndrome or REDS. This is significant because we have research to show that a decreased carb intake, even for a few days. So again, a lot of you are probably like, oh, a few days, it's been months or years. That decreased carbohydrate intake is going to increase a protein called hepcidin in the blood that blocks iron absorption. Okay. So even if you're here and you're like, my ferritin's low, I'm going to take a supplement. I'm going to take some Hemaplex, highest dose possible because I need to get me some iron. If you're not eating enough carbs, a lot of that's not getting absorbed. It's not really doing anything because the issue might not have been iron. It's carbs. It's energy. Your body's really smart. And I'm going to go into a lot of other like issues that I see. That again, a lot of the times, if we do some more digging on like, well, why are these issues happening? It goes back to the fact that we're not getting enough carbs and this affects everything. Especially if we're continuing to try and train at the level we want to train at, no matter what level of athlete you are. So we can't out supplement low energy availability. We have to eat the carbs. You can't get around this. So if this is an issue, then we don't need more information. We need help with the implementation, maybe with the belief shift, maybe with the actual application of nutrition principles. Probably don't need more information. If you're not getting at least 6 grams of carbohydrate per kilogram of body weight per day, as someone who exercises at least 5 hours a week, you're not getting enough carbohydrates. And a lot of you probably need far more than that, okay? Especially if you've been like in a state of low energy availability before, you need more in order to fill the gap and come out of the hole. Again, if we are over supplementing anything like zinc, copper, calcium, these things compete with iron. So this can be an issue. I saw this a lot during the pandemic. People were taking a bunch of zinc because they heard it was good for their immune system. And I was like, this is definitely throwing off your immune system. And it's also throwing off things like other minerals and iron. So if you're like, oh, I'm doing that and I don't really know why, because I was not told to by a doctor or a practitioner, maybe time to reconsider. If you have a copper IUD, I've seen this throw off ferritin status because, again, increased amounts of copper in the body can mess with iron status. I don't see that super commonly, but it does happen. Too much iron supplementation, you're right, can throw off iron status. Isn't that crazy? So, again, if we take too much iron, this is a Goldilocks thing when it comes to absorption. We're going to increase that protein again called hepcidin, and it's going to block iron absorption. So we need to get the dose just right in order for the max amount to be absorbed. So there's a lot of different ways you can incorporate this. It can be supplementing iron every other day. I tend to not recommend that a lot just because I see people having a hard time implementing that. It's easier sometimes to remember to do something every day versus every other day. So take what you want with that, although there is some research to support every other day supplementation can decrease hepcidin and therefore improve absorption rate. Again, we don't just want to take more iron. There's some studies showing like 100 milligram iron supplementation can help improve status, but I just don't see that at all in practice personally. Like I see the high dose supplements like Hemaplex tend to not help people or put them into iron overload, or it doesn't even change their iron status because it's too much. It's like an 85 milligram supplement. So again, more is not always better. Most of my clients, I'm able to give them a really low dose of iron supplement and get much better outcomes if the iron supplement's even needed in the first place. Iron supplement etiquette can be helpful to know, but within reason. So we want to take iron typically on an empty stomach, which looks like taking it about 30 minutes before eating or about 2 hours after eating, but then 30 minutes before eating again. And this can be really hard for people to implement. If you run first thing in the morning and you're trying to fuel your runs and you're not fueling your runs because you're like, I got to take my iron supplement, we have a problem because guess what? That underfueled run is going to make hepcidin increase more because that is a protein that increases with acute inflammation. and you're not going to absorb much iron. So we really want to be careful with this. And again, if you're like, I'm trying to fuel my runs, but it's hard because I'm trying to get my iron supplement in. Well, guess what's probably, kicking your iron status into a hole? Underfueling. So we want to prioritize, again, the root cause approach first. We need to fuel adequately. We need to get the timing good. We want to be doing that stuff. And sometimes it's good to know for people, if you can take the iron supplement, usually like first thing in the morning or even like at the end of the day, although research shows hepcidin levels tend to increase by the end of the day and be lowest first thing in the morning, which might help with iron absorption. That might help you. If you don't tolerate your iron supplement super well, switching forms to something like iron bisglycinate can be helpful and better tolerated, cause less constipation, less side effects, those types of things. I've also seen people not tolerate that version at all and do better with iron sulfate or ferrous fumarate or a different form of iron. And if you're like, I don't really tolerate any of them, you could try taking it with food, which is going to decrease absorption, but maybe improve your toleration and you'll get a little bit, from the pill. So again, there's a lot of different ways to approach iron supplement etiquette, but within reason. We don't want to be sacrificing our fueling at the expense of getting an iron supplement in because we're getting it backwards if we're doing that. If you've got medications that you're trying to not take iron with too, that can be tricky. So that's something that we help people with in practice. Overtraining. So everyone seems to think that overtraining has to look like, oh, I run like 100 miles a week, or I run 60 miles a week, or I run this many miles a week, or I do this much cross training. It is relative to the person. You're going to see overtraining if you have low energy availability at any level of athlete. So if you're running 10 miles a week, but you're not eating enough, you're overtraining and you're underfueling. And we got to fix one or both of those things to make the math equation of energy availability work out. If you are running 120 miles a week as an athlete, but you're freaking crushing your fueling and your recovery and you have appropriate off seasons, great. Maybe you don't have an issue. Maybe you're not overtraining at all. So this can happen at any level. But a trend that I see is people will train for a spring marathon and then they'll train for a fall marathon and then they'll train for a spring. And these are just recreational people, especially. But elites, are not immune to this either, obviously. They'll train for several marathons, 2+ per year, but they won't take an appropriate off season. They won't take at least 2 weeks off after their race. They won't take a period of time where they are not training as intensely because they're afraid they're going to lose fitness. They're not switching up their training to something that's not just foot strike hemolysis, like strength training, cardio, that's not running, extra rest, these types of things. And they're in a low state of energy availability that builds really gradually and sneakily over time until bam, their iron status is low. They've got other nutrient deficiencies. They've got some of the low energy availability symptoms and they're like, maybe I should do something about this. So what do? They're like, I'm going to go try to eat more food. I'm going to take these carbohydrate recommendations and I'm going to try to match what, is relative to my current training status. And they try to eat more, but they're still training pretty hard and they're not changing anything about that. And you're not going to come out of the hole usually with that approach. Usually coming out of the hole looks like scaling back the training. So like not signing up for a marathon and also eating more. And depending on how long you were in the hole, this has to happen for a bit, okay? Sometimes it's a season. Sometimes it's I'm going to skip my marathon in the spring. I'm going to do some 5 and 10Ks. And I'm going to really try to eat more and reduce my volume and intensity and like really give this a good effort. And they're good to go. They can do a fall marathon, no problem, because they're recovered. Sometimes it's like, ooh, I've been building this hole for years. So I'm going to take a whole year or maybe 2 or maybe 3 off of that higher volume training and really, really, really approach this differently. And that's how long it can take sometimes, okay, to improve your energy availability, to improve your symptoms, to improve your micronutrient statuses. And like there's a lot of psychological components of that too that I don't want to discount because I've been there. So overtraining increases hepcidin. Doesn't matter how much iron you're taking. If that hepcidin's increased, you're not going to absorb it. So that's something we want to consider. There's other factors too. Like, are we missing something? This is when clients who sign up to work with us sometimes they're just like, dang, Holly, like, you know, I when I worked started working with you, I thought you were going to teach me how to use like sports drinks on my long runs, but now I'm being diagnosed with celiac disease. What the hell? um, and it's like, yeah, I'm just more than you bargained for sometimes. Because we do some digging here that needs to be done because you're not getting better with the typical interventions. So again, like if your ferritin's low, you're taking iron and it's just like not improving, or you constantly need iron infusions, which is a red flag, by the way. Especially if you don't know why you constantly need iron infusions. And if it's just, oh, because you're a runner, that's not a good enough reason. Um, you know, and like these things I talked about previously don't necessarily resonate as much. Celiac disease, IBD. We want to check for blood loss in the GI tract, especially diagnosable conditions like these. Celiac disease can be tested through blood test screening. You have to be eating gluten, though, for that to be more accurate. And the gold standard is a biopsy in the small intestine. So, pretty involved process. IBD probably involves getting a colonoscopy and speaking with a gastroenterologist. So, again, these are things we want to rule out. There can be other things going on in the GI tract. H. pylori, which can contribute to ulcers and reflux. This is huge. I see this so often on stool tests that we do with clients that it got to a point where I was like, is this test rigged? Do I need to look into this? And then I did one on myself and I did one on people who were not runners and no H. pylori. It's like, oh, okay. So it's just like my avatar that I'm looking at all the time that tends to struggle with the same thing all the time. But people who are properly fueled or who aren't beating the crap out of their bodies trying to run marathons once or twice a year don't seem to struggle as much with this. Got it. Because again, a lot of the times, even if we do have things like H. pylori, candida overgrowth, other functional GI issues, hypochlorhydria, dysbiosis, small intestinal bacterial overgrowth. If we have some of these trendy, like, wordy, functional GI issues that are very legitimate things, we still want to ask why. Why? Why is our GI tract in a place where this can grow? A lot of the times we can trace it back to antibiotics, especially if you had to take multiple rounds of antibiotics or got IV antibiotics. This might be something that happened if you had group B strep and were pregnant. You know, under fueling, like low carbohydrate intake, under fueling, overtraining, super common causes of these things, which is why I see them all the time in my clientele. Chronic stress, again, why I see this all the time in my clientele. Very high achieving individuals, very badass people that I work with who are like, I'm going to run half and full marathons. I'm going to train for Ironmans. I'm going to do all this, on top of working full time, on top of being a parent, on top of managing a household, on top of my hobbies, on top of my other responsibilities. And I'm going to burn myself into the ground and not even have time to eat enough, let alone if there's other eating issues going on. So chronic stress, that's really hard on the nervous system. And guess what? Your gut is directly connected to the rest of your nervous system. So very, very legit there. Eating disorders. Whoa, yeah. So there's an obvious cause of probably poor fueling. And that's something that we'd want to address again with a multidisciplinary approach. We also know that eating disorders are very commonly underdiagnosed. A lot of even general practitioners, we have studies on this, say that it's important to diagnose and screen for eating disorders, but most of them don't know how to do that properly. We have research showing this. So that's something that often gets missed. Or maybe disordered eating. It's not like an actual, it doesn't fit into a perfect eating disorder DSM-5 box, but it's still a legit concern that's going to affect your fueling. Wilson's disease, which is a genetic disease that affects copper status, which again, as we know with the iron recycling process, can mess with your ferritin status, thyroid issues. This happens to a lot of my clients too. They got a stubborn low ferritin. We learn they have, thyroid autoimmunity or other thyroid issues and or are taking medications that can alter their iron status. So again, we want to get to the root cause of understanding how to properly intervene there from a holistic standpoint. And boom, we might get a better iron status out of that and also just have you feeling more well as a human because you're better managed. Autoimmunity in general is a really big category that affects iron issues. It can lead to falsely elevated ferritin because ferritin can be falsely elevated when there's a lot of inflammation. It can also lead to chronically low iron status. So autoimmunity doesn't always come with a diagnosis, right? We have I have a lot of clients who I would say have autoimmunity, but they haven't fit into a box for a diagnosis. Like they don't have, rheumatoid arthritis. They don't have Graves. They don't have Hashimoto's. They don't have celiac disease. They don't have type 1 diabetes. They don't have, lupus. They don't have these things, but they have some wonky lab values that basically are, they're being told we just kind of have to wait till this gets worse before we can medicate you. That makes me sad. Because we can usually do things to help keep you in this place or improve the situation through diet, lifestyle. Again, approaching this with a bigger picture in mind. Status, medication is not the only intervention for anything, usually, especially autoimmunity, which is a big gray area, but that can contribute to your iron status. I see that all the time. Or again, just chronic inflammation. If there's chronic inflammation, we want to go inflammation hunting and understand where that's coming from, so that we know why. I've had clients come in and they've got lab values that I'm like, this looks like a trauma victim that was in a car accident that lost a ton of blood, but you're just like walking around doing your job and like trying to run 30 miles a week. Like, whoa, like what's going on? And then usually I'm sending them to the ER or urgent care or their PCP to get evaluated. And we discover, oh, turns out you have IBD. Or, oh, turns out you have celiac disease. Or, oh, turns out you're just really, really underfueled and you've got like a lot of gut dysbiosis going on. You've got ulcers, you've got candida. You've got poor absorption, and you're just living with that. Or like, oh, you have undiagnosed autoimmune conditions. Or, oh, you have like mold exposure and we need to do something about that because the spores are leaching iron from your system. So, and it's usually not that straightforward, by the way. This usually takes some time to figure these things out and do the digging that no one's done before because we've just been told take an iron supplement. And they did, but then it didn't get better. So there's a lot of different reasons why this can happen. But again, what I see the most common in practice is not the big, scary, crazy, weird thing. It's the, hey, I'm not eating enough carbohydrates. I'm overtraining for how much I'm eating. And I need to really adjust that long term in order to see a meaningful change with or without supplementation. If you've had stress fractures in the past, it's highly likely you have low energy availability, especially if your ferritin or iron status is also low. And we need to really address that probably more aggressively than you have been if you don't want to get more stress fractures, if you want to feel better, if you want to prevent some more severe clinical complications, and improve your iron status. Other reasons why it could be low that I see as like a catalyst type of root cause are pregnancy and childbirth. I have a hypothesis that like a lot of women go into pregnancy a little bit iron depleted, especially if they're an athlete, who may or may not have low energy availability, because again, it's hard to eat enough to support the type of training I know a lot of you are wanting to do, myself included. They get pregnant and then their iron needs go up a lot in pregnancy because we increase our blood volume in pregnancy and have to grow, like a whole human and a whole other organ called the placenta. So we're just told, oh, you're a little anemic. It's fine though. It's just because you're pregnant. Nothing we can do about it. Or, hey, just take an iron supplement. But we're not addressing the root cause, which was, yeah, the iron supplement maybe, but also the overtraining, the underfueling, the disordered relationship with body image and food preventing us from eating more, et cetera, et cetera, et cetera. Maybe some gut issues that rose as a result of that are further leaching iron from the system. It's also really common for people to have autoimmune conditions triggered during pregnancy and birth that happen a year or two after the fact, after giving birth. And I feel like no one tells you that, but that's a thing. um, then they give birth, which is a very blood loss heavy event, very traumatic event. No matter how the baby comes out, you're going to have blood loss. Sometimes you have more blood loss if you hemorrhaged or if you had a C-section. And again, we don't really ever tell anyone to do anything about that postpartum. No follow-up labs a lot of the times. No ferritin labs ever, usually. And I feel like a lot of women too, they just jump back into their exercise routine. They continue underfueling, except now they're also trying to breastfeed, which is further depleting them. And of course, we have a low ferritin status. Of course, we have a low micronutrient status. Of course, we have a low iron status and don't feel good. And they just don't get the advice or interventions that are actually going to be helpful to get us out of this hole. And 5-6 years later, that's when they're in my office because they're like, I feel awful. I'm trying to say that it's not awful, that it's just like not that great, but I don't feel great. And I'm trying to exercise more. I'm trying to hit a marathon PR again, but I got bone injuries, or my thyroid won't calm down, or I got all these gut issues now. I can't sleep. I have poor libido. I just don't feel like myself. And they're told, oh, it's just because of motherhood. And it's like, yes, that's of course a factor, of course. And we have to look at this with some common sense here holistically, which again, like our system just does not really do, especially when it comes to athletes. Because maybe you did actually tell this to your doctor and they were like, oh, of course. And they did all these labs and then your ferritin was 25 and they were like, you're fine. You're just a mom. You're tired. Right. So, in my eyes, I'd say, oh, that's a sign that we are not eating enough. We need to dig deeper. We need to address this. So those are options too. Heavy periods, I mentioned. That's something that, again, if our periods are heavy, we want to understand why. So we're not just slapping a Band-Aid on the issue. Sometimes the periods are heavy because the iron is low and the underfueling is happening, or the other issues contributing to the iron being low, but then the periods being heavy make the iron lower. Slippery sword, right? Or double-edged sword, slippery slope. I combined two things. Perimenopause. This is a really big thing too. If your periods are changing a lot, because you're kind of going through perimenopause, maybe you're over 45 and this is starting to happen. This can be significant as well. And then again, once we go through menopause and we don't get a period anymore, that can cause your ferritin status to actually improve sometimes. But we might still miss some underfueling, if it's still there. So that's something we want to consider. Surgery, obviously. I think it's obvious, but it does happen. Medications, if you're taking PPIs or antacids for acid reflux, again, I want to know why, because these things decrease your stomach acid further. And sometimes a decreased stomach acid is the reason why we have reflux. So it makes the problem worse and decreases iron absorption. So this can be an issue. If you're taking a GLP-1, this can deplete us of nutrients as well if we're not eating enough, especially if we're not eating enough while exercising too intensely for the season that we are in. Chronic, NSAID use. So if you're someone who pops Advil like it's a vitamin, that can contribute to GI bleeding and iron loss. H2 blockers and other types of medications, treatments for chronic diseases, all of these things too can deplete your iron stores and affect your iron status. So it's just kind of good to know if that's contributing at all. And again, understanding like, why am I taking this in the first place is important. Maybe you know why. Maybe you're like, I'm being treated for cancer because I have cancer. Okay, duh. Obviously, we're going to keep doing that. But maybe you could feel a little bit better during that treatment if we're able to address micronutrient status. But if you're like, yeah, I am on a PPI for reflux, but I don't know why I have reflux. It just kind of happened. And yeah, maybe I am underfueling. Again, this is the digging that we help clients do. You made it to the end. So hopefully this helps give you some insight as to why your ferritin is still low, even though you're taking an iron supplement or got an iron infusion, and or maybe this has triggered some light bulbs to say, maybe I need to get some labs done because I have a lot of these symptoms, or I am suspecting this of myself. And you're like, what do I do next? So if you need support with this, we have a program called our Iron Athlete Bundle that incorporates my Iron Athlete Masterclass, which is a hour plus masterclass that's pre-recorded that talks about this even further with visuals and intervention tips. You also get a 1 hour one-on-one consult with either myself or another team dietitian, depending on availability, to go over the lab work that is also included in this bundle that incorporates the lab work we discussed in the podcast episode to get an understanding of where your iron status is at. Note that if you are located in certain places outside of the US or places like New York, New Jersey, Rhode Island, Hawaii, some other states as well, you may need to provide your own labs, which we can always help you understand how to advocate for yourself within your own providers, or go to a third party like Quest or another third party as well. If you have recent lab work already that includes all of these things, and I would say recent for iron is probably like within the past 3 to 6 months, you can send that to us as well. And we can, add on this lab panel to recheck as part of the bundle, because again, we're going to have to recheck. You also, of course, get guidance in that hour consult on like what to do next. Like, we're going to assess your diet, supplements, medical history, and understand, okay, why could the iron deficiency or the iron issues be happening that we discovered on the labs? Or, hey, let's look at these labs because this actually doesn't show iron deficiency, insufficiency. So why are you tired? Like, let's talk about that. Or, hey, I think further testing like a stool test or a referral or something else could be needed. So here's what we're going to do next. So this is a bundle as kind of like a gateway to your iron journey that may or may not stop with the bundle. To be completely transparent, a lot of the times we are probably going to need to also incorporate another consult or another lab panel, or another form of test or referral to a provider to help us understand why the iron is low or why it's not moving. But this is going to give you that personalized, individualized insight. So you're not just leaving this podcast going, oh my God, super interesting, I think that applies to me, but then not actually doing anything about it. And that bundle is $399. So you can go check that out based off of availability. The link to it is in the show notes. And if you do need more support outside of that, that is something that we can discuss as well. But I hope this was helpful and insightful, and a little bit more insightful than your typical iron podcast episode. That's like, your iron's low because you're a runner and your ferritin needs to be higher and take an iron supplement properly. Because it is about a lot more than that. That comes down to us usually asking you more questions, getting further assessment, and understanding where to go from there. I've had clients, work with me where, and my co-dietitian as well, we've had clients work with us where we incorporate interventions and it improves right away. And that's awesome. It goes from like stage 1 insufficiency, their ferritin's 30. We incorporate appropriate interventions based off of their unique case, and their ferritin goes up to 50, within 2 months, and increases, from there, or stays stable from there. We've also had clients where, it takes a lot of investigation and honestly time and resources, which can suck. But at least we know we're going in the right direction, because we learn, all right, we tried the normal interventions. Those didn't work. Okay, now we need to do more lab work. Okay, we did more lab work. Oh, wow, that showed this issue. Now we need to approach that issue in this way. Okay, we did that and fixed that. Did the iron change? No, it didn't. Okay, so maybe that wasn't the cause. Okay, well, what about this? Oh, this is an issue. Okay, let's approach this. Oh, wow, we got a celiac disease diagnosis. That's crazy. Okay, now we're going on this gluten-free journey. And over the course of a year, maybe 2, that's when their iron starts to respond. Okay, so it depends on the person, But know that a lot of the times it's somewhere in the middle. Like iron status can take a few months to respond in a meaningful way. And that doesn't always mean that it's going to be within normal limits, but it should mean it's going in the right direction. And trajectory wise, over time, if we keep doing the right thing, it will be within those optimal ranges for an athlete. And also, again, this is coming from someone I've had low ferritin before. It's something I've struggled with because of underfueling. Honestly, too, because of poor iron intake, because I didn't eat iron-rich foods for a long time, and because of overtraining, because of heavy periods, because of childbirth. Like I've had low ferritin throughout my life that I've been able to address and improve and now optimize where I can expect it to be over 40 most of the time I go to get it checked, unless there's been something like childbirth, in the mix. So I get it. I really do get it. It's a journey, and it's something that, again, it's something we should be checking usually at least once a year. If there's an issue, though, and we're incorporating interventions, probably 2 or 3 times a year. So hopefully this was helpful. Go check out the Iron Athlete bundle if you haven't already, and let me know if you have any questions. Happy fueling!